I am Meredith Hirsh.
And I'm Mike Chavez.
And this is Working Healthcare, where each week we tackle the messy, meaningful forces steering America's nearly $5 trillion healthcare system. Today, a bill with a poster card name could redraw the map of who gets care and who doesn't. It's called the One Big Beautiful Bill Act. Supporters say it streamlines hospital payments and modernizes Medicaid. Skeptics warn it could close the doors on rural America. 1 in 5 Americans live in a rural county, yet more than 150 rural hospitals have shuttered or scaled back since 2010. When the only ER for 60 miles goes dark, trauma care slows, costs rise, and the ripple reaches city hospitals too. Maternity wards are usually the first to vanish. Medicaid now covers 41% of births nationwide, nearly half in many rural counties. Yet, hospitals often lose money on every delivery. The question is simple. Can small facilities afford to keep bringing babies into the world? And can communities afford for them not to?
That brings us to our guest.
Carly Salamone spent a dozen years inside a rural hospital, moving from community outreach to lead health improvement while studying public health. In 2022, she joined Fisher-Titus Medical Center, 50 miles between Cleveland, Toledo, and Akron, right at the epicenter, where outdated rates, new payment rules, and post-Dobbs realities collide daily. She now heads policy there and chairs Vantage Healthcare of Ohio, a network fighting to keep rural beds open.
So what does the One Big Beautiful Bill Act actually change in our American healthcare system? How did we get here with Medicaid, and where might we be headed? Could site-neutral payments rescue rural care or hasten its decline? And 3 years after the Dobbs decision that reversed Roe v. Wade, how is maternity care really faring beyond the city limits? Big stakes, big questions.
And I'm really glad you brought those up, Mike. So, Carly Salamone, welcome to Working Healthcare.
Thank you so much for having me. I'm so excited to be here and talk about all things rural healthcare, rural hospitals, and that big, beautiful bill that everybody keeps mentioning. So.
And that is what I definitely want to talk about in the history of Medicaid, so we can really get a clear understanding and share with our listeners what's going on, because you're hearing fighting from both sides of the aisle. So what exactly is the One Big Beautiful Bill Act, and what's at stake for hospitals as we move forward?
Absolutely. So the One Big Beautiful Bill, which everyone has heard so much about, was signed into law on July 4th from President Trump. And it outlines not just healthcare provisions, but really, as most people know, it's across the spectrum, right? But the goal was to decrease costs significantly within the budgets to offset tax cuts for some American people. So what are the health provisions within the bill, and why is that impacting Medicaid? Well, the first is that overall, it looks at an $880 billion cut in Medicaid costs over the 10-year period.
So I want to talk about that, and I want to step back because I want to dig into Medicaid, because I know you know the history of Medicaid and what people opting in to take in and states accepting Medicaid, yes. Right? Medicaid payments from the U.S. government. How did this situation start within our American healthcare system, with Medicaid payments really being the core crux of what hospitals, specifically rural hospitals, rely upon?
Yeah, absolutely. So I'll go back in time a little bit, but historically, Medicaid has been medical assistance insurance for those underserved communities, specifically when it started looking at women and children, so people below 100% of the federal poverty level, pregnant women, and children under the age of 18 who did not have health insurance. And so for a really long time within our country, Medicaid was primarily focused on that, as well as, those with disabilities. And then there is care for the elderly as well in conjunction with our Medicare system.
Right, and that's
Now,
Medicare, and you can be Medicare, Medicaid, which people aren't necessarily aware of, and Medicare covers 80% of patients' health care, and the Medicaid, if they're Medicare, Medicaid, covers the remaining 20% out of pocket, because there actually is a cost for those 65 and over to take Medicaid.
Correct. But if you're under a certain, poverty line, then that Medicaid also kicks in. Another thing that most people don't realize for our elderly population is if you go into a nursing home, you are also then on Medicaid. I like to use the analogy that Medicare funds the healthcare, Medicaid funds the room and board, right? So people don't really understand those are all cuts that will be impacted by this big, beautiful bill as well. However, so prior to the ACA, it was restricted to those groups of people. When the Affordable Care Act came into play, one of the topics, in addition to, everybody has a right to healthcare coverage, and we need to make healthcare more affordable for the average American and the marketplace and all of those things. One of the big things that came through was Medicaid expansion, right? So that said, if you did not have children, even if you were single, even if you were a man, if you were below a certain poverty line, you too could qualify for Medicaid, right? So we opened the door to access for a large group of people who were previously uninsured.
Correct. And when the Affordable Care Act came into play in 2010, it was actually mandated that Medicaid expansion was going across all states. And then there were legal fights. And in 2014, I may be wrong on that date, but that's what I recall, is that when the legality was finalized, when the dust settled, it was the state's choice if they wanted to take Medicaid expansion. And to date, 40 states plus the District of Columbia accepted Medicaid expansion, including Ohio. Florida, where I'm located, did not accept Medicaid expansion. So we're not feeling the ripple effect of this one big beautiful bill to the extent that these 40 states and the District of Columbia are going to. So could you explain a little bit why Ohio and all of those other 41 areas accepted Medicaid expansion, what it gave to them?
Absolutely. So obviously you want to say that they did it because it was the right thing to do to offer affordable health care, but there's another component, and that big component is that Medicaid expansion was a 90% match from the federal government, right? So for every dollar put into Medicaid, 90 cents was brought forward for that expansion population compared to your other Medicaid population at about 60%. So there was an incentive to draw down more funds from the federal government by expanding Medicaid. And it did cost the states less money for that expansion population compared to your children's health insurance, your what's termed ABD, age blind disabled, and your prenatal population. So there was big incentive to do that for the states, and that's a lot of the reason that states were able to afford that.
And to even go back to the start of the Affordable Care Act, it also required employers to provide health insurance. And employers who did not want to pay for health insurance in states that accepted Medicaid expansion were actually let off the hook, because if they were paying an employee $15 an hour, that employee actually fell below the federal guidelines and could actually get Medicaid, from my understanding. And so that's why we have all of these able-bodied workers that at one time did not qualify for Medicaid and now qualify for Medicaid, and the employers were let off the hook because the state government gave their employees Medicaid. And so they didn't have to provide insurance and these ERISA plans that are the employer-funded plans. And so now we went from pre-2010 to post-2014, a huge number of Americans who are now on the Medicaid payroll. So what is the One Big Beautiful Bill Act actually doing with their budget cuts?
Yeah, a couple of things. First is that it does put work requirements into effect for everyone who is part of that Medicaid expansion population. So monthly, you have to submit work, either proving 80 hours a month of work, community service, or other benefits. And if failure to produce that information can lead to your termination from your health insurance from Medicaid.
Unless again, I want to say, Carly, unless you are disabled, right? You've proven your disability.
Correct. Just for that expansion population, right?
Is
So
there
this
an
is
age
not
requirement on that?
impacting
Does that fall
it
under
is
an age requirement too?
19 to 64.
Right.
So
Gotcha.
it's, yep. And again, it doesn't touch the original Medicaid population, right? So children, families, just those who are disabled, that doesn't impact. It's just that expansion group. Second is redeterminations every 6 months. And so a lot of people say, what does that mean? When you have a commercial health insurance, right, every year your employer says, fill out this form and tell me which plan you're going to pay for, right, you want, and that's about it. When you go on any kind of federal insurance, specifically Medicaid, there's a lot of paperwork involved. You have to prove your income, you have to provide documentation that shows that you're legal citizens, you have to provide all sorts of things, and typically that's done once per year for Medicaid. It's an annual redetermination to show that you still qualify through our local jobs and family services here in Ohio, at least. This law, or this big beautiful bill, actually makes that go to twice a year, which, as somebody who worked with the Medicaid population for 12 years in my former role in infant mortality prevention, it is hard enough to have somebody redetermine every year, to remember, to be able to get to JFS, do all of those things. And so we are going to see a lot of people lose their coverage simply because they don't know that that their redetermination is up. 2, they don't have all the documentation they need. And 3, it takes a while to get all of that process. So making that twice a year is a significant burden.
What is that burden? What is that process?
Yeah, so here in Ohio, you go online, you fill out an initial application, you make an appointment with the local jobs and family services, and they tell you everything that you need to bring with you, right? Like I said, it is any income verification, pay stubs, tax returns, your children, if you're bringing your family in with your children's birth certificates, your birth certificates to prove that you were actually citizens, right, born here in the United States to qualify. And then whatever those work requirement documentations are going to be. If you have the documentation, that's one thing, and that's one obstacle. But the other thing that most people don't realize if you're not in it daily is how hard it actually is to get an appointment. How long it actually takes for paperwork to get processed, right? And the burden that we're going to put on these little, when I talk about rural communities, these little rural county job and family service people to do double the work when they barely have the staff to do it once a year.
And I think that's I was going to stop and say, I think that's a really great comment to make, Carly, and I appreciate that. If anybody's ever tried to get their driver's license renewed and has to go in person, right? If anybody has to get their passport renewed in person, you start this process a year ahead of time, right? So now we're talking every 6 months. Anytime I have to call reemployment with our state system, you're on hold for like 2.5 hours. It's the most insane thing. We've like nailed it down to calling on Wednesday at 9 a.m. We tend to do best then. But it's a game that you have to play and you have to figure it out. So I can only imagine the craziness to go through the re-verification every 6 months. Why did these 10 states not take Medicaid expansion? Why wouldn't Florida take Medicaid expansion?
Because I'm not going to make assumptions. I'm just going to say what I think might be the case, and that is that there's still a cost to the states and to the taxpayers. So on 90%, if there's a 90% match on that Medicaid expansion group, there is still that 10% that has to be fully funded by the state. And that's a consideration, right, that isn't always taken into account, especially going back to the big beautiful bill. One of the things that they talked about was decreasing that federal match for the Medicaid expansion population, right? Like I said, it's 90%. And 14 states who are currently Medicaid expansion states put in what are called trigger laws to say if the federal government reduces that, it's called the FMAP, the federal match, we will pull Medicaid expansion from our state. And Ohio is one of them.
So how do these trigger laws affect you in Ohio and these 13 other states as opposed to the others that took Medicaid expansion? What's a trigger law?
Yeah. So the trigger law essentially says if the federal government comes back and says they're going to reimburse match less than 90% of that FMAP, all of Medicaid expansion goes away, right? So right now we're talking about increased reporting requirements for that Medicaid expansion population. We're talking about work requirements and redeterminations, but that is not the same as no one that's within that expansion population gets Medicaid. So that would be even more detrimental than what we're already discussing right now.
So how many patients in Ohio are going to lose their Medicaid insurance with the trigger law?
750,000.
That's
Ohioans,
astonishing.
Would lose their. Yes, they are in that expansion population. But thankfully, right now, we're not there yet, and hopefully we won't be. There are other provisions of the Big Beautiful Bill that are going to cut the Medicaid reimbursements to hospitals for that expansion population that are put into effect, things like the decrease or the cap on the provider taxes and state-directed payments, which we can talk about. But all in all, this Big Beautiful Bill will decrease Medicaid spending in rural areas by $137 billion over the next 10 years. So $137 billion in Medicaid cuts just to our rural communities over the next 10 years because of all the provisions that are being put in place.
I think what people are unaware of is, and I know my emergency room doctors who listen to this podcast have brought this to my attention. Many of the patients that they see are Medicaid patients. So while hospitals get reimbursed much higher than clinics that Mike and I are affiliated with, I mean, up to 4 times the amount, we don't take Medicaid, and we don't have to take Medicaid, but hospitals can't turn away patients. So from my understanding, hospitals rely on this Medicaid expansion to supplement, right, the non-payments that they're getting for patients in which they have to care for.
So there's a couple of distinctions I want to make in that, but correct, right? So it's not just Medicaid on average reimburses about 64 cents on the dollar for every for the cost of healthcare, right? Not profit, the actual cost to provide that care.
Which is why we don't take it.
64 cents.
Right, which is why we
don't
take it.
And you don't have to, right? But further than that, hospitals don't just have to take Medicare and Medicaid, which is true. They have to provide care to the uninsured, right? So we're not even where, again, you don't have to take that as a private practice. So it's not, that 64 cents on the dollar is better than zero for that uninsured patient, that self-pay patient. We call them no-pay patients, right? That's not anybody's fault, but you go to the emergency room and you're self-pay and you get a $15,000 bill, you can't pay that, right? People like to say hospitals have become subprime lenders, right? We don't have a choice, but we are still providing that care and serving as that financial lender, for lack of a better term. So there's that distinction between Medicaid provides some reimbursement, 64 cents on the dollar, compared to Medicare, which is 82 cents on the dollar on average for the cost of care, compared to what happens if those people become uninsured that were previously Medicaid. 64 cents is better than nothing. And so that's really the argument at this point in time, which is crazy when you think about it, right? Because we're not asking to be paid at 100%, right? We're just saying, well, that's better than what would happen when people lose their Medicaid.
But for every dollar that the state contributes to Medicaid, the federal government is contributing $9. So it's, as you had said, the federal government is giving 90%, the state government is giving 10%. From my understanding, DeSantis was governor at the time and did not accept Medicaid expansion because he said, what the federal government giveth can taketh away. And it is not something that we wanted to be a part of and be tied to the fact that what do we do if the federal government takes away these $9 for every dollar we're putting in? People will lose their insurance. Let me ask you, for all of those employed right now who are on Medicaid, and if Medicaid expansion goes bye-bye, or all of these, right, you have to prove that you're working and go through all of that. Is there any responsibility that's passed on to the employer under the Affordable Care Act?
So I think that's another important distinction. The Affordable Care Act does still require employers to offer health insurance as long as you are above a certain size as an organization, right? But so it wouldn't change any of that. But the problem is that a lot of people who are making minimum wage can't afford their health insurance through their provider, right? I mean, think about it. And I pulled some data earlier today. I know for myself what it costs for me to get insurance through my employer just for me and my 2 kids. But in Ohio, the average cost for a family of 4 is potentially $18,500 per year for their medical insurance. That's between their deductibles, their co-insurance, and their premiums, which on average employers pay 58% of. So if you're making minimum wage or you're making $10 to $15 an hour, you can't.
And listen, even if you're making $25 an hour,
insurance.
Carly, even if you're making $25 an hour, you can't. I mean, I'm looking at, I'm listening to your statistic of $18,000 and think that's incredibly low, actually, because if I'm looking at my family and we are on an HSA plan and our premium is $1,900 a month, we're on Florida Blue, and our individual deductible is $3,700. Our family is like $6,000 if I recall. And that doesn't even include out of network, right? So there are meds, denials, right? It gets insanely crazy. I did the review of what I am paying, and I'm like too embarrassed to even say what I pay for healthcare every year for my family, because a lot of the physicians that my family has to see or medication isn't covered by the health insurance. So it's far more than people even make a year. Hence why we have this podcast, to try to explain really the inner workings and what's going on. So I'm going to do a shout out. If you listen to Working Healthcare, please, we're doing awesome with our 5-star Apple Podcasts and Spotify reviews, but I really encourage everybody to leave a 5-star Apple Podcast or Spotify review because it increases awareness. It brings us up on search engine optimization. It lets people know we exist because you have an amazing story to tell. You really started on the maternity side. So how is this big, beautiful bill impacting the maternity side and what's going on, even in the big cities, for those who are like, I'm in DC, this doesn't impact me?
Yeah, great question. And I still, like you said, I started in that world and I love to talk about it. And you mentioned briefly in the introduction about rural maternity deserts, and those are really real. And I'll give you a little bit of background as to why it's always been an issue, but this will make it worse. On average, Medicaid reimburses about 50% of the actual cost for a delivery, okay, on average. Now, about 40% of all deliveries nationally are to mothers on Medicaid. That increases to 50% in rural communities. So 50% of moms coming in to deliver in these rural hospitals are on Medicaid. So 50% of whatever income, or whatever reimbursement you're getting is already less, about half of what it actually costs just to the cost of care, right? Again, there's no profit margin in Medicaid. And then you look at the number of births coming into rural communities, right, into rural hospitals versus their urban counterparts. And you see it's very hard to keep up a rural maternity ward when you're having 2 to 3 births a day, right? And that's only paying, maybe you put them together, 70% of what the actual cost is to care for those patients. when we go back to, I just lost the headphone. When we go back to the
Big Beautiful Bill Act and how it's impacting maternity.
Yes, the Big Beautiful Bill Act, we talk about specifically provider taxes. We didn't get into it much, but what a provider tax is it is non-state dollars. What the state does, the state taxes the healthcare providers, and then the healthcare providers pay the state to help with that federal match. The more money we put up, the more money we can draw down, and that increases those Medicaid reimbursement rates, even if it's just for that expansion population. So what happens when overall reimbursement rates across the hospital drop? Well, programs we're currently subsidizing, like maternity wards, which are being subsidized 99% of the time, right? They do not cover costs. They're just an essential service. Will have to go away. Tough decisions will have to be made. And over the last 5 years, from 2010 to 2022, 238 rural hospitals lost their obstetric services. And the percentage of rural hospitals without OB services went from 43% to 53%, right? So those continue to close. In our region, I would tell you in the last 5 years, we've lost 13 maternity wards just in our region here in the northern half of Ohio. Wow. And so what happens, right? It's not that they don't want to serve. Maternity is a great benefit. It's so essential, right? And it's actually good things happening in a hospital compared to so much bad. Mm-hmm. But we can't keep subsidizing it if we don't have the money to pay for it. And that's really the big thing, right? We see, we see big systems. They're closing their maternity wards in their rural communities, and they're pushing everybody to their flagship hospitals in the big cities. So more people deliver there. That helps them to potentially profit, at least offset those costs, because it's all going to one place. But it's eliminating care in these essential rural communities.
And what I've shared is I went to high school in Eau Claire, Wisconsin, which I wouldn't consider a rural community. However, it is, even though probably nobody listening to this podcast has ever heard of Eau Claire, Wisconsin, but interesting statistic, at one point, the cost of milk was based on how far you were from Eau Claire, Wisconsin. So there you go. But it is 86 miles east of St. Paul. And it's about 2.5 hours from Madison, west of Madison, Wisconsin. It's about 4 hours west of Milwaukee. So there aren't other big cities around Eau Claire, but the rest of Wisconsin is rural. And so you have these other communities going to Eau Claire to get the help that they need. And there's a large Medicaid population in these rural communities in Wisconsin. And so I went to go visit last summer, and 2 of the 3 hospitals had closed down. And the only reason the 3rd hospital hadn't closed down is because contractually it couldn't. And so the next closest hospital, I think it was Sacred Heart Hospital, was one of the ones that closed down. Their affiliate was in Green Bay, Wisconsin, which is about 3.5 hours from Eau Claire. So everybody who needs help, you end up going to the Twin Cities. That's far. You're like schlepping an hour and a half to get over to a hospital in the Twin Cities. And so it's really impacting states. Like Eau Claire's got to be the biggest city on the whole western side of Wisconsin. And so What do you do?
Yeah, exactly. Well, a couple things. One, you drive and you hope that you left your house early enough to get there before you deliver a baby on the side of the road, right? You call 911 because in case you deliver on the way, at least you're with EMTs, but then all you're doing is taking away emergency services from somebody who could be having a heart attack, right? Or number 3, people go into their local hospitals that don't have, OB, labor and deliver in the emergency departments, but none of those things are good because even hospitals with emergency departments aren't equipped to handle any kind of concerns that may happen to mom or baby. It increases morbidity and mortality risks for both maternal mortality and infant mortality.
And you've
right?
done a lot of
Is an emergency.
and you've done a lot of research on that, and I want to hear about it because it's staggering. You do a lot with is there infant mortality that is different for white moms versus moms of color versus rural moms versus moms in the big city? In all of the research that you've done, what have you found? And then again, furthermore, how has this impacted the rural community?
Yeah. Two pieces, right? Overall, nationally, Black women are 2.5 times more likely to have an infant die before their first birthday, right? As opposed to white women when we talk about urban communities or suburban communities. And that's really due to all of the factors that come into play prior to a woman ever getting pregnant, one of them, right? What we look at as preconception care, right? Are we, do we have comprehensive sex education? Are we healthy before we get pregnant? What stressors have we been exposed to throughout our lives? How are we planning and spacing our pregnancies all of those things taken into account. That's not blaming the mom. It's just the environments that we're raised in, right? So overall, Black women have 2.5 times greater rates of infant mortality than white women.
Do you think, Carly, do you think it's education, or do you really think it's based on the color of the mom's skin?
So there's a couple different components, but I do think that we see higher rates of cortisol in the body in African American women compared to our white counterparts, just based on the discrimination that's been faced throughout their lives or the circumstances that they've been in. And then you can add in, if they grew up in a home where there wasn't access to nutritious foods, or they didn't know where the next meal was coming from, single parents. And not to get too deep into the data, but the research shows that your DNA is impacted from all the way back to your grandmother, right? Because your grandmother carried your mom, and you are born with all of your eggs. Right? Mm-hmm. So your grandmother carried your mom, who was carrying you, right? So it's not just a one generation solution. So looking at that when we talk about our urban disparities, when we look at our rural disparities, it's access to care. It's some of the same concepts in terms of education, preconception health, and education interconception care, right? But even bigger is that access issue. And so it's not just about, I'm sorry, go ahead.
No, I was just going to say, and so since the Dobbs decision in 2022, which reversed Roe v. Wade, for those listeners who aren't aware of that, what changes have you seen in maternity care, specifically in rural hospitals? I don't know what happened in Ohio, if Ohio allows for abortion or doesn't, but I'd love to hear what's going on in your state, because in Florida, we're certainly struggling a little bit.
Yeah, so Ohio, it kind of went back and forth, and last November it was on the ballot, and Ohio did overwhelmingly approve a woman's right to choose, and so that has been a positive here. So I can't speak specifically to my hospitals when I talk about the impact that we've seen, but on a national level, abortions aren't just a choice because it's an inconvenient pregnancy, right? There's so many reasons for why women are making those choices, and sometimes making those choices with their physicians because of the outlook of the baby, or because of the care, the medical condition of the mother. So Roe v. Wade and that whole component will continue to drive up infant mortality rates, maternal mortality rates, and maternal morbidity rates, because it doesn't take into consideration what's healthiest for mom and baby. And that will continue to have consequences. I know that, go ahead.
Are we seeing a decrease in those unwanted pregnancies because of the change in Dobbs? Or are people still getting knocked up left and right? I don't know how else to ask it.
I've seen some research recently that's showing we have one of the lowest birth rates on record these last couple years here in the States, but I don't have any data.
Yeah, I don't know. Inevitably it's going to decrease, but how do you even know what you're decreasing to be able to track it. So it's probably something that's so hard to manage and track.
Yeah, I don't know, but I would think that the number of pregnancies have definitely decreased, and I don't know what that benchmark is because none of us are physicians and study that. And of the three of us, Carly is the most experienced because at least she studied public policy. But look at South Korea; their birth rate's like 0.3%.
Yeah.
Like South Korea is going to cease to exist pretty soon. It's insane. And I think ours is 1.8.
Yeah, I don't even know at this
Yeah,
point.
it's
but
definitely
I'm hearing,
decreasing.
Yeah.
Almost every country in the world is decreased. I learned that from your husband, Mark.
Well, that's good. Well, you haven't repopulated yourself, or
I
at
have
least
not.
that you know of.
Switching gears.
I have. In Judaism, we say 3 children. You replace the mother, the father, and you have an extra to tag along. So I did my 3. I think, Carly, you're at 2.
I'll get working on that.
I am. I'm at 2, and we are done. So I didn't follow my Judaism rule because I am also Jewish, but I did my part. But you know what? I think that that's an argument that some people will actually make. Birth rates, decreasing birth rates, is actually an argument that some people are making for why we don't need to continue to fund rural maternity wards.
Wow.
I'm not going to say who, but I've had that very specific discussion. Well, birth rates are decreasing in that area. Well, maybe if we were providing access to health care, right, and we had the financial backing of the system, which we could talk about the economics involved with the closure of a rural hospital, right? If we were bringing in more jobs, we would have, what we could consider a growing population. Rural communities are aging, right? They're not growing. And so birth rates are going to continue to decline until we have that younger generation coming back to where they're from, right? Yeah. To have children and raise up families.
It's an interesting topic, and it's been the topic of a lot of podcasts lately, and there's been so many reasons thrown out there, everything from like the decrease in testosterone in males as the reason why. So, I mean, it's all over the spectrum as far as like the reasoning behind it.
Yeah.
It's an interesting conversation.
You don't know. And then we have a whole nother topic with HHS and the defunding and all of that. And I feel like every other post I put on LinkedIn has something to do with Health and Human Services that's killing me right now, because you have sometimes you have to use a scalpel, right, and not a jackhammer.
Well, and I would love to say that the reason our birth rates are decreasing is because we're offering comprehensive sex education across all of our communities, and therefore, they're educated on how to prevent pregnancy, but I also don't think that's the case.
Yeah, I would concur with you on that one, Carly. Are you seeing more babies with NICU needs, though, or complications because of the delayed prenatal care or the closure of these maternity wards?
I don't want to speak to something that I haven't seen firsthand just because I'm not in the hospitals anymore and in the hospital daily anymore in my role. But I do know that is definitely an issue that is happening across the country. I mean, increased, babies are, coming out sicker sooner, that kind of thing, especially, and this has been ongoing for a long time. Even hospitals that have OB care, they don't have maternal fetal medicine. They don't have all that specialty, care for pregnant women. So they still have to go hours out to the big cities for that specialty care. And then you run into 800 other barriers that prevent them from getting there. So there still is that lack of access to care, even if there is a hospital that will deliver the baby in the community. And
one of the big topics right now is site neutrality. So I'm pivoting a little, but it's in part of the proposed Medicare fee schedule, right? And the proposed Medicare changes is site neutrality. And this is a really hot topic for us being in an independent practice. And I've learned so much by hosting Working Healthcare because I've learned more about the hospital perspective, and especially just in this short time with you. What is site neutrality? And if we get site neutrality, how will this negatively impact hospitals? Yeah, so brief overview. So currently, Medicare reimburses for services at what are termed hospital outpatient departments at higher rate than physician offices. Paid under that Medicare physician fee schedule, right? And the OPPS, the outpatient payment fee schedules as well.
So what site-neutral policies aim to do is equalize Medicare reimbursements, whether that service is provided in a hospital outpatient department or a physician's office. And we had this conversation, and from a physician's office perspective, it's, well, of course, why would you pay the hospitals more, right? When they're providing the same service. However, this is another one of those policies that will disproportionately impact rural hospitals. And there's a couple reasons for that. The first is that rural hospitals heavily depend on outpatient services, and 75% on average of rural hospital services are outpatient, right? Medicare, there's obviously higher levels of Medicare patients being seen in rural hospitals. On average, 70% of all patients are Medicare and Medicaid, right? And the third reason, and the biggest reason, because that still doesn't get why it shouldn't be equitable, right? The biggest reason is that hospital outpatient departments are treated as part of the hospitals, and therefore they have much more stringent conditions and requirements than your outpatient physician practices do that are not hospital affiliated. Hospital outpatient departments and hospitals, they require 24-hour care. They have strict accreditation standards, right? And surveyors coming through. They have to have emergency plans in place at all times. And so that comes at a higher cost overall to care for these patients. The other thing to consider when we're talking about it from the standpoint of hospital, the hospital outpatient is that these patients that are being seen at a hospital outpatient department versus a physician practice are normally sicker. They're sicker, they're more complex, which is why they're, in communities where there is a choice, there isn't always, but in communities where there is a choice, people are getting taken care of at the hospital. Because if something goes wrong, you're right there for all of those emergency services versus the lower complexity patients who can be seen on an outpatient basis.
Critics would say that if it's a more complex patient, you could just bill a higher complexity code. If you need to go in for surgery, you're billing that surgical code. If there's a bed stay, right, somebody needs to stay overnight or be admitted to the hospital, there is a code affiliated with that. That is not something that a private practice, independent Part B, Medicare Part B provider would provide. So what do you say to combat those critics?
I mean, I think it goes back to the fact that hospital outpatient departments, especially in rural communities, have so much more requirements in place and have that 24-hour access to care and have all of those systems that cost more money. It's more costly to operate a hospital outpatient department than it is to operate a physician's practice that does not have to adhere to all of those standards at the end of the day. If you don't want to pay them more, don't make them accountable for more.
Well, what you shared with me, which I had never thought of previously, is that, you have to be open 24/7. So even if nobody is walking through the door, you're still staffing as though anybody could walk through the door. You have to have all of these types of patients, right? You have to have all of these different types of physicians staffing the hospital. I mean, in Florida, our medical malpractice rates are so exorbitant that there are a lot of hospitals that don't have certain specialties. And so I don't know where these people go. I mean, they get air flighted, whatever the terminology is, over to Broward County, over to Miami Jackson Memorial Hospital. So it becomes a little crazy. I also think it's really important to point out that doctors don't necessarily get paid at Part A rates. There are a lot of doctors who contract with the hospital. Their employees, they have to bill under Part B. And that's why a patient who goes into a hospital may get 3 separate bills. They might get the hospital bill, the physician bill, and maybe the surgery center bill.
Mm-hmm. Right. Yeah, or you might get, say, it is a surgery, you may get an anesthesia bill, you may get a surgeon bill, and you may get a facility bill, right? And so those are important things to note. The other one, right, when we go back to 24/7 services, that's not just your emergency room, right? That's pharmacy, that's housekeeping, that's nurses and doctors and all of those things. And so there is so much more to dig into when it comes to site neutral. It's not as cut and dry as it's being made out to be.
And you are so involved in policy now, and that's really where your passion is. You shared a personal story with me about changing jobs and how it affected your healthcare coverage. Would you mind sharing with our listeners? It's a really great example of how somebody who transitions jobs, it impacts them, like their premiums or out-of-pocket costs, in ways that people might not expect.
Yeah, absolutely. More than happy to share. And it goes back to our conversation about why it's not affordable for most people. Working in the hospital, and having that hospital insurance, people don't always realize, hospital self-insured, but they really offset those costs for their employees. That's one way that they really keep employees. And so moving from paying a very low premium for our healthcare in the hospital to the private side of a smaller company, and recognizing, wow, I went from paying $150 a pay to paying $400 a pay just for me and my 2 kids. And then that's $800 a month. And then we have a family deductible of $10,000. And then we have our co-insurance after that, right? That 80-20 split. But even further than that is you switch insurance plans, and all of a sudden, the people you've been seeing for years, your physicians, right? Your mental health practitioners, right? Your physical therapy, everybody, may not be in network anymore. And they're just supposed to end those relationships after this really extended period of time because your health insurance changed. And the reality of the situation is no. If you can afford it, right, which is a big if for most of Americans, you want to try and keep that healthcare within that same organization. And so for me personally, coming into the end of the first half of 2025, I have spent over $15,000 for me and my 2 children in our healthcare. And that's a whole other discussion for another day, but it does go back to, why is Medicaid expansion so important, right? And how do we make healthcare affordable again?
So that's what I want to ask you. I do want to ask you, what would it take for maternity care to become financially sustainable in rural hospitals? What would it take? I mean, is it really local leadership's responsibility? Is it the state's responsibility? Is it the federal government's responsibility? And what would it take?
I think it's a great question. And at the end of the day, it's increasing reimbursements so that maternity care is actually covering the costs of those deliveries. And so there's a couple ways to do it, but at the end of the day, it could be the federal government providing more match for pregnancy, right? And then in turn, the state increasing the reimbursements for those pregnant patients. Or it could be, something similar to a critical access hospital model where they pay 100% of costs just for those OBs. But there's a lot of different ways we could do it, but right now it's just not sustainable.
So I'm going to steal Meredith's final question. If you could create one change within our American healthcare system,
oh my gosh,
what would it be?
You were waiting for it, Carly.
I already have it in my mind, and it's a very unpopular opinion, but national health care. And 10 years, I'll tell you this, 10 years ago, you wouldn't meet a hospital CEO that would tell you that. But today you will hear that something is better than nothing. And people say that it'll cost too much for taxpayers, but think about how much we pay for our health insurance or just for our health care. Like that, I would take a tax increase over an unknown amount of money that I'm going to have to pay because health insurer decides that my care wasn't necessary.
Well, you're bold enough to say it because some people don't say it on the podcast and then they whisper to me afterwards. I didn't want to say it because it's so unpopular. I still don't think that's the route to go. And I'm going to be interviewing someone very shortly. You and I both know him. He doesn't think that's the solution. So I'm curious to hear what Preston Alexander has to say.
Yeah, absolutely. And I mean, the first line is hold insurance companies accountable. And Preston Alexander, and you will get into that significantly, and I could go off on another whole hour on if we're holding insurance companies accountable, then we would decrease the cost of care. But really, it's like that meme where there's like three, everybody's pointing a gun at each other, and there's three people, right? Who are we actually to blame for where we're at, right? The hospitals people think are bringing in billions of dollars, the health insurance companies, the pharma companies, and everybody's got their gun drawn.
We know it's
right?
the PBM though, Carly.
That is the health insurance company.
Yes.
Integration. So I could go a whole other direction on that. But right? So there's no quick answer. There's no simple fix. That's my really simple response to a very complicated problem.
Well, Carly Salamone, this was amazing. You are a wealth of knowledge. I really enjoyed speaking with you, and I really enjoyed you breaking down. I know Mike did, right? The one big, beautiful bill.
I did. Yeah.
I'm getting him into policy.
I actually learned a lot.
So thank you, Carly.
Good. Yes, of course. Thank you for having me.
To everyone listening, the full video of this episode is now live on YouTube. Just search Working Healthcare and hit subscribe so you don't miss future interviews, short clips, and behind-the-scenes moments. And if you've got a question, an episode idea, or someone you think we should feature, drop us a line at meredithhirsh.com.
And if this conversation hit home for you or made you think a little differently, don't keep it to yourself. Share the episode, tag a friend, or post it on social. You can follow us at Working Healthcare on Instagram, Facebook, and YouTube. Meredith and I are also available individually on LinkedIn. That's where we keep the conversation going between episodes. The more voices we bring into this space, the more momentum we build. Because change doesn't start with a policy. It starts with a conversation, a real one like this.
New episodes drop every Tuesday. Subscribe and don't miss what's next, because you can't fix U.S. healthcare until you understand how it works. I'm Meredith Hirsh.
And I'm Mike Chavez.
Tune in weekly as we explore the inner workings of healthcare.